Hello everybody. So today we're going to be approaching this a little bit differently. I have briefly looked over this, but I didn't add a bunch of extra material into it. I had a little bit before kind of getting started because I kind of want to take you through in this video kind of how I would approach going through this material almost on my own and learning it myself, or kind of relearning it, recapping it, as well as adding in those bits and pieces of extra information for you guys. So we're going to be talking about spinal motor reflexes. Okay, this is actually a really, really cool concept, and you'll actually learn more about this when you get into neurology, it's neuroanatomy, and also clinical neurology. Those two courses, you'll talk a bit more about these reflexes, kind of the pathways that they take, and why these things work. So first things first, what is a reflex? So the reflex is I kind of want to say that the reflex is more of the process of which you have a stimulus and then the reflex occurs and then you have a response to that stimulus. The response itself is not technically part of the reflex, but it's more like when we talk about it, it's the way that it occurs. Okay, so the definition that we use here is responsive stimulus without the need for cognitive processing. That means that it skips the brain. The main benefit of this is that we don't lose any time in translation, okay? We're able to have something happen like at our hand or at our foot, and our body immediately responds without having to think like, hey, that hurts, I need to move. And that can help us prevent further damage from happening to the body. These are specific, predictable, and also involuntary response to specific stimuli. Majority of the stimuli that we're going to talk about is going to be pain stimuli. Noxious stimuli is what it's called. So noxious, so it equals painful stimuli. Just so we get some vocab in there. Again, that advantage is that rapid response time. So we can see here in this picture, we have sensory receptors. These sensory receptors go all the way back through the dorsal root ganglia into the posterior aspect of the spinal cord, also known as the dorsal horn. It's going to synapse with a motor neuron on the front, go down through the ventral or anterior horn. We can go back to the skeletal muscle. And this sensory receptor, it can be within the muscle itself, or it can be in the skin or another place. And we'll talk about like when there's an interneuron versus when there's not an interneuron. So this beautiful little chart is going to talk about kind of grouping reflexes. Each of these, the correct wording would be are a piece of the reflex. So for example, we can have an innate reflex or an acquired reflex. And those innate or those acquired reflexes can either be spinal or cranial. And then all of that, so you could have an innate spinal reflex that is monosynaptic. And that innate spinal reflex that is monosynaptic could be somatic. So that's kind of looking at this where you have these different parts of the reflexes. Some of our innate reflexes, innate meaning that these are things that we just do on our own. We don't have to process them. From the time that we're born, we have these at the time that we're born, we have these reflexes. So stuff like blinking and also palmar grasp. When you have a baby, a really, really little baby, and you kind of put your finger in their hand, they immediately just grab on. That is one of the reflexes. They don't have any control over that. It's just a reflex that they have. Acquired reflex would be conditioned reflex, kind of like vomiting or salivation to certain things. Those certain people, those who are really, really sensitive to somebody gagging or somebody else throwing up, that's an acquired reflex. Salivation as well as an acquired reflex, because when we start to get around specific foods, especially, or we smell specific foods, we start to salivate. That's a learned reflex. Spinal reflexes, we'll go over a couple, the withdrawal reflex and the knee jerk. And then there are also other cranial reflexes like blinking, salivating, watering the eyes. You'll learn more about those cranial reflexes and kind of what they are in neurology and clinical neurology. Monosynaptic versus polysynaptic. Monosynaptic having one synapse, meaning that there is one nerve connecting to one other nerve. Polysynaptic means that there are multiple synapses. Somatic deals with the muscles, and visceral is talking about the smooth muscle and the smooth and cardiac muscles, as well as the glands. So those things that we don't have any voluntary control over. Okay. So looking at these reflexes, we have a monosynaptic and a polysynaptic reflex. The big difference here between these two is this interneuron right here, meaning that there is one synapse, two synapses, there's multiple synapses. With the monosynaptic, it goes straight from our sensory, our receptor, straight into our somatic motor neuron. So the way that we're going to name these, we have a receptor. A receptor in this case, if we're talking about the knee-jerk reflex, which is mostly what we'll talk about here at the beginning for our monosynaptic reflex. Our receptor is the muscle spindle. A stimulus occurs, and the muscle spindle picks it up. Remember, the muscle spindle is part of the intrafusal fibers. And this is one thing I really want to note. The stimulus itself and the response, neither of these are actually part of what we call the reflex loop. Reflex loop is from the receptor to the target cell. So all of this part, this receptor sensory neuron into the spinal cord, efferent neuron, and the target cells, that's all the actual reflex loop. The stimulus and the response aren't counted with the reflex. Again, this is how I was taught it. This is how I learned it. If for whatever reason your professor is saying something different and they want to include it, that's up to them. Make sure you listen to your professors. Continuing, the receptor transmits to a sensory neuron. The sensory neuron in this case, specifically for our knee-jerk reflex, is going to be a type 1A nerve fiber. Sweet. And then we go into the spinal cord. It synapses onto a somatic motor neuron. This is also going to be known as an alpha motor neuron. And then those are going to go to the skeletal muscle to cause the movement to occur. Polysynaptic is very, very similar. It has this interneuron in between, and we'll talk more about that a little bit later. So here is our reflex arc, reflex loop, or arc, however you want to call it. It's the same thing. You have the receptor, the sensory neuron. You have an integration center. That's who here with this interneuron. And then you get a motor neuron, and you get onto the effector. So it's important to understand this is going to be this is a polysynaptic reflex loop, or reflex arc. With a monosynaptic reflex arc, this is going to be gone. Okay? We're not going to have that interneuron in between these two. Big things I want you to remember about these reflex arcs is that the sensory part, sensory always enters from through the dorsal horn. So that is the posterior portion. The dorsal horn is the back part of the spinal cord. The back part of the spinal cord is always going to be dealing with our it's kind of the sensory side of things. Our motor always leaves through the anterior horn. And specifically, we're talking about the anterior horn of the gray matter here. The inside, this little butterfly, is the gray matter. The outside portion is the white matter. Okay, so we have our dorsal horn, our anterior horn. This little piece right here, especially if we're up more like in the cervical spine, or kind of into the thoracic spine, really, this is going to be known as our lateral horn. You don't need to know much about the lateral horn right now. That's going to deal with, let me make sure. Yeah. The lateral horn, which is found in the thoracic, upper lumbar, and sacral, is the central component of the sympathetic division of the autonomic nervous system. So that's our sympathetic nervous system. You don't need to know that right now for this. Just focus on the posterior horn and the anterior horn, or the dorsal horn and the ventral horn. Posterior dorsal, anterior ventral, and good to go. Okay, so we have the receptor. It goes through the sensory neuron. What's the type of sensory neuron that we typically use? Remember, type 1A is the one that we're going to focus on in this class. Those who go and they synapse into the motor neuron, the motor neuron is going to carry it to the effector organ. The receptor, in this case, specifically for the muscle, if we're talking about the muscle, our receptor is what? It's going to be our muscle spindles. What kind of fibers are muscle spindles? Muscle spindles are intrafusal fibers. And then the motor neuron goes to what kind of fibers? Muscle fibers. They go to the extrafusal muscle fibers. Okay. So organization of the spinal cord for the motor function. We have the gray matter is the site of integration. So the gray matter is this whole part here in the middle. The sensory, or the afferent, this is a vocab real quick. Afferent versus efferent. Efferent, if I can spell. Afferent, if for any of you that speak Spanish, a is to or towards in Spanish. So afferent is towards the CNS. Okay, it's going from the outer tissues to the spinal cord in the brain. Efferent is going away from the CNS. Okay, don't get those two confused. You will have questions that depend a lot on that, and it's easy to read one as the other. Okay, so our sensory portion is afferent. The sensory is going, the information enters the dorsal horn of the spinal cord, and then the spinal cord brings it up to the brain. Yeah, so our afferent signals go up to the brain, and our efferent come down from the brain to tell us kind of what to do. The anterior motor neurons, located in the anterior horn, which we already talked about, give rise to alpha motor neurons and gamma motor neurons. We'll get into exactly what each of those do. Before, the alpha motor neurons are going to go to the extrafusal fibers muscle. The gamma motor neurons are going to go to the intrafusal fibers. Just want to double check. They're divided in, motor neurons are divided in two groups. Alpha motor neurons innervate extrafusal fibers, and gamma motor neurons innervate intrafusal fibers, which contract only slightly. Remember, our extrafusal fibers are going to be our voluntary fibers. Our intrafusal fibers are non-voluntary. These guys are involuntary. They're just hanging out. Okay, our alpha motor neurons, they innervate the muscle fibers, our extrafusal fibers. We talk about neuron branches, and they stimulate a few to several hundred skeletal muscle fibers. Motor units. We've talked about motor units before. Remember the definition of a motor unit. Motor unit is a single alpha motor neuron and all the muscle fibers it innervates. This is important to remember as well for large movements versus fine movements. We were talking about the muscles. So for fine movements, we have really small motor units like the fingers. So we have more motor units per area. Whereas large movements, think like the quads or the hamstrings. Large movements, large motor units. Cool. Then we have gamma motor neurons, which gamma motor neurons are involved in our whole dealio with the reflexes, mostly focusing on kind of resetting or recalibrating our intrafusal fibers. And we should get more into this specifically later on when we really start talking about the everything itself. Maybe we'll see if it gets. I'll mention it here just in case it's not later on. Like I said, I haven't gone through this whole thing specifically. So the gamma motor neurons are responsible for going to the innervating the intrafusal fibers, which are within our muscle spindles. Remember, the muscle spindles specifically are our stretch detectors. They sense how much and how fast a muscle is lengthened or shortened. So the muscle spindles, we're talking about stretch. Spindles, stretch. Or lengthening, stretch. Okay? Muscle spindles are our stretch detectors. Later on, we'll talk about Golgi tendon organs, and though it's important to differentiate what their functions are, where the Golgi tendon organs detect tension, whereas the muscle spindles detect stretch. Okay, so I'm actually going to go back up here for a sec to show you this picture. Let's actually draw our own. So right here, let's say we have our Golgi tendon organ. Not our Golgi tendon, sorry, our muscle spindle. This is our muscle spindle. The muscle spindle has wrapped around it this nerve. What's this nerve? This is our type 1A muscle spindle. And very, very rapidly and very suddenly, this muscle changes length. Let's say like we get grabbed and our arm gets shoved really quick. Or in this case, when we talk about the knee jerk reflex, we get hit with the little reflex hammer. Okay, all right, on our patellar tendon. And that causes the length of the muscle to very, very quickly lengthen, because when we hit it, it pulls and stretches and it lengthens the muscle. So our type 1A afferent fiber is going to send that signal all the way over to our spinal cord. And specifically, it's going to go in our dorsal horn. Here's our dorsal root ganglia right here. So pretty. Goes in through here. Then it's going to synapse onto our alpha motor neuron, which goes out through the front. And this goes to our beautiful muscle. Telling it what to do. Now, so this is what's happened. So now, let me make sure this is our alpha motor neuron. Secondary to this, we have another little thing coming out here. A second synapse. And this is our gamma motor neuron. It's still going to come out the front, but it's going to go to the muscle spindle. It's our gamma motor neuron. Because when our alpha motor neuron goes to our muscle, itself, part of the reflex is that it's going to cause the muscle to tense up. It's going to cause it actually to contract in order to oppose the sudden quick change in length so that the muscle doesn't get damaged. So as the muscle belly changes length, we need the muscle spindle to know exactly how much length, or what the length is, what the stretch is of the muscle, to be able to keep sending this signal to our central nervous system. And this is a secondary to this. Sorry, one sec. She wanted to be included. Okay. So this is just part of the reaction part. Okay? This information from the type 1A sensory afferent neuron is still going to travel up the spinal cord to the brain. Okay? The information is still going to get passed up into the brain. The muscle spindle, you can kind of think of the muscle spindle, trying to think what a good indicator for a muscle spindle is. The muscle spindle is constantly giving feedback to the brain. Constantly. It's giving a pulse, like, we're good, we're good, we're good, we're good, we're good, giving a steady rate. As soon as something changes in the muscle stretch, then it'll change its rate at which it signals to the brain. And that sudden quick change is also what gives us that reaction. Okay? But the muscle spindle, we need to communicate to the brain then what's happening to the muscle. So our gamma motor neuron is going to come and innervate the intrafusal fibers of the muscle spindle to get them to match the tension, or not the tension, sorry, match the stretch. So match the stretch of the muscle tissue. So that way it can continue to send an accurate signal about what the muscle is doing. Additionally, let's say, for the knee-jerk reflex specifically, this muscle right here are going to be the quads. If you think every single muscle has an antagonist muscle group, meaning a muscle group that does the opposite function. That other muscle group, in this case, the opposite of the quads, is the hamstrings. They also are going to have a little sensor here. So this is the alpha motor neuron that goes to the hamstrings. Of the hamstrings. And this signal from our type 1A afferent is going to release a chemical meteor called GABA. If we look everything else here, and up to the brain, all of those are releasing a chemical called glutamate. Glutamate. All of these three are releasing glutamate. Glutamate activates in the spinal cord. Glutamate activates in the spinal cord. Glycine inhibits. Glycine with an I inhibits. Glutamate activates. Glycine inhibits. So here being released is glutamate. Glutamate to activate our intrafusal fibers and to activate our quads. At the alpha motor neuron of the hamstrings, we get glycine released. And that is to inhibit or to block this alpha motor neuron from firing in order to cause relaxation of the hamstrings. It forces the hamstring to relax so that way it does not interfere with what the quads are trying to do. And that's like the whole chunk of the big loop. Let's go back to the PowerPoint and kind of see where we're at with all of this. I'm sure I got ahead of us quite a bit. Okay, we talked about the intrafusal fibers, kind of their function. They're to make sure that the muscle spindle stays accurate and matches the muscle tissue around them. Talking about the organization of the spinal cord for the motor functions, we have interneurons. They're present in all areas of the spinal cord. They connect to neurons. There's 30 times more numerous than anterior motor neurons. So there's a crap ton of interneurons. Okay. They're very highly excitable, and they're found between most sensory neurons and alpha motor fibers in the spinal, and they are located in the spinal cord. We also have something called Renshaw cells, or inhibition of motor neurons. So Renshaw cells, or inhibitory interneurons, prevent excessive or uncontrolled muscle contraction. They're located in the anterior horn of the spinal cord. That's where our muscle neurons are. They have collateral branches of the alpha motor neuron to provide input to Renshaw cells. So here's a little Renshaw cell, and our alpha motor neuron, it goes and connects to it. So it's coming, the signal is coming from the 1A afferent. It comes and it goes down here, and another little signal comes here at the same time. It's going down. These participate in recurrent inhibition. So recurrent inhibition, kind of like how if we looked at the action potentials, remember how we had that period, that refractory period, which kind of paused and stopped things from occurring? That's kind of the same function of the Renshaw cells. The Renshaw cells provide a negative feedback system, meaning that they stop what was happening before, that prevents the rapid, repeated firing of the same motor neuron. Okay. So one branch of that axon loops back towards the cell body of the neuron and communicates with an inhibitory Renshaw cell. So as a signal gets sent down towards the muscle, the signal also comes and tells the Renshaw cell, like, hey, make sure that we don't get repetitive signals over and over and over and over again. And that prevents something called tetany. If you've ever heard of your tetanus shot, in microbiology, you should also learn about the tetanus bacteria. Called the Clostridium tetani, or Clostridium tetani. What that bacteria actually does is prevents the inhibition of these muscle fibers, and tetany is actually literally, let's see if he goes into it at all. Let me pull up something else that I have. Must have another. Probably have it on another slide. Another PowerPoint somewhere. But yeah, so the goal is to prevent tetany. Tetany is muscle spasms, so the muscle repeatedly firing over and over and over and over and over again. And that bacteria actually causes your muscle fibers, to your muscles, to literally fire nonstop, and they lock up and they seize and they spasm. And that can be very, very dangerous. Actually, known with the tetanus bacteria, it can kill you, but it's also there is situations where if you don't have a vaccine or you don't have a treatment for it, and you get the infection, it's kind of a clinical tidbit, not really important for your test or anything. It can cause the muscles to contract with such force that it's been known to break your own bones. So it causes your muscles to just fully lock and contract, and just snaps your bone because of how much force is being placed on it. Kind of crazy. Okay. Continuing, the muscle spindles in the Golgi tendon organ. So skeletal muscle contraction, it needs a stimulus and also a feedback. So feedback is controlling it, typically will have a negative feedback or a negative feedback loop or a positive feedback loop. Positive is also called a feed forward. You'll learn more about feed forward loops in Physiology 2, but we'll mostly talk about feedback, negative feedback. Okay, so the alpha motor neuron stimulates the skeletal muscle cells. It receives continuous feedback about the length and tension of the skeletal muscle. These should be separated right here. So the alpha motor neuron is going to stimulate the skeletal muscle, and our muscle spindles and our Golgi tendon organ are constantly giving feedback about the length and the tension of the skeletal muscle. You need to make sure that you remember the difference between these two, that one is length, spindle, length or stretch. This has an L in it. Tendon, tension. Try and remember those. Make sure that those are clear in your brain, the difference between those two. And so both of these are giving continuous feedback about the skeletal muscle up to the brain. So this general function of the muscle spindles, we already kind of talked about this. They don't contribute to the muscle tension generated, so they're not actually part of the contractile force of the muscle. The spindles have a few myofilaments. They're found on the terminal ends of the muscle spindle, so these terminal end here and here, those are the extrafusal fibers. These are still technically intrafusal fibers, but these ends here, these at the very end, these pink part, these are intrafusal fibers surrounded by extrafusal fibers. And that's what is going to where the gamma motor neurons go to. They're found on the terminal ends of the muscle spindle. They are located in the belly of the muscle, so in this center, to help sense the change. And they provide feedback for the length or the rate of length change. It detects changes in muscle length, changes in length during muscle contraction, and maintains intrafusal tension when muscle is at rest. They contain intrafusal fibers, anywhere from 3 to 12 intrafusal fibers, and very few myofilaments, actinomyosin. So again, they have a couple of the myofilaments of the actinomyosin because they need to be able to adjust and maintain the tension to be able to give an accurate signal. It's not super important. That's why you have your alpha and your gamma. Alpha motor neuron, go here, gamma motor neuron. Sensory type 1A is coming from this. There's also a sensory type 2 afferent nerve ending. We don't talk a lot about that in this class. We'll touch on it in a couple of different places. If your professor goes deeper into wanting you to remember that, then go ahead and do that. Let me see if I can find... I haven't seen him go into it yet, so I might not touch on it unless it comes up. Okay, he touches on down here. Okay. When we get to it, we'll go over that, which is actually right now. The sensory rule. So the muscle spindle's sensory fibers, they have sensory innervation. The receptors are found in the central portion. Remember, the muscle spindles are located within the muscle belly, within the actual muscle fibers. There are two types of sensory endings. We have the primary endings, also known as the primary afferent. These are our group 1A fibers, found in the central portion of each intrafusal fiber. These have a rapid conduction of signal, 70 to 120 meters per second. So think about how fast that is, 70 to 120 meters per second. That is well over the size of a football field in a single second, which is pretty crazy how quickly these things happen in our body. We kind of break them down and oversimplify them almost, just to trying to understand them a little bit. But understand that these and thousands and thousands and thousands of these signals are occurring every single second, all through your entire body. It's amazing. We also have the secondary endings, or the group 2 fibers. When we say usually one, sometimes two fibers, it means we're going to essentially always talk about the group 1A fibers. Those are the more important. Those are the primary fibers. And sometimes you'll also have type 2 fibers. Not necessarily all the time. You won't always care that much about the type 2 fibers, but it's fine. And those type 2 fibers can be found on either side of the primary ending. We also have here, we have two different sensory portions. There's two different types of sensory tissue within the muscle spindle. We have the nuclear bag fiber and the nuclear chain fiber. The nuclear bag fiber is going to have those group 1A fibers wrapped around it. The nuclear chain will have type 1A and potentially type 2 fibers on it. So those are the ones, those highlighted, those are what we want to remember. We want to remember that nuclear bag has type 1A. Nuclear chain has both type 1A and type 2. So those nuclear bag fibers, nuclei form an expanded region of the muscle spindle. They call them bags. The chain fibers, no expanded region of this region, no expanded region of this cell of the area. The nuclei are spread along the fiber. Both fiber type primarily activate group 1A fibers. The nuclear chain fibers excite the group 2 fibers, the secondary afferent nerve endings, which is what we literally just said. Getting ahead of the PowerPoint. More about muscle spindles. So the primary and the secondary endings participate in static response. They generate almost proportional impulses based on the degree of stretch. Dynamic responses are mediated only by primary fibers. When we say primary fibers, we're talking about the type 1A fibers. When the muscle length changes suddenly, the rate changes. The impulses increase during stretch and return to baseline after muscle length stops lengthening. Continue to function during muscle shortening. The frequency action potentials decreases. So this is what I was talking about earlier when I said that they have a constant signal that they're delivering, where they're giving this sort of all good, all clear. What it makes me think of, if you ever watched SpongeBob growing up, there's the episode where SpongeBob and Patrick are on the Flying Dutchman's ship, and he's back in the ship in between rocks, and he's like, "You're good, you're good, you're good," and the ship is getting destroyed in the entire time they're in the process. That's what it kind of reminds me of, and that's how I like to think about it. Just helps me kind of remember what it's supposed to be like. So it's kind of like that, where if we're moving slowly, with the muscles, if we're not moving at all, we're just stationary, we're relaxed, we're getting a signal, we're good, we're good, we're good all the way through. And then as we move more, as we begin to stretch, or as we stretch quicker, that signal increases. It's still steady, so it's still going at, like, let's say if this first one is at, let's say, 10 beats per minute, this next one's at 60 beats per minute. But it's constant, letting us know what the rate is. And when we have those intrafusal fibers, they stretch to match the tension of the muscle to be able to give this proper signal. Here is our stretch reflex. It's divided into dynamic and static reflexes. Dynamic means moving. Static means not moving. When you get into your palpation courses, you'll have different listings. You'll have static listings and dynamic listings. Dynamic. Your static listings are stuff like position asymmetry of the vertebrae. So you'll have an LPC4. That means that the left part, the left articular pillar has gone posterior. Or a dynamic listing, you'll have a right rotation restriction of C4. So that's the actual motion, the movement of the vertebrae. Similar concept here, where the static is stationary, dynamic is moving. So if the muscle spindles are stretched suddenly, excitatory signals are sent to the spinal cord, so there's type 1A. And they directly synapse with the alpha motor neuron to go to the muscle, and that is the monosynaptic reaction. So in this case, it's like adding a sudden load to it, and then the muscle immediately senses it. And this is also part of this is also like, if you see the load being applied, it's kind of cool that the brain will actually begin to auto-calibrate for it. And you start to like tense up your muscle more as it's going on. But if you don't see it and it's a very sudden adding of the load, your body like very quickly responds to it, and that's thanks to this stretch reflex. The excitatory signals are sent to the spinal cord, the impulse sent towards the stretched muscle, the alpha motor neurons. The stimulating contraction and extrafusal motor and intrafusal motor fibers are stimulated. So here we have our stretch reflex. We get a muscle stretch. Our muscle spindles sense that. We get increased afferent signals to the spinal cord. And the spinal cord, increased efferent output through the alpha motor neurons, and the muscle contracts. And then the firing rate of the afferent sensory neuron decreases, which again brings us back to, it decreases in its firing that at a slower rate, which then stops us from over-contracting. Muscle spindles smooth out muscle contractions. That's another thing about the muscle spindles. They prevent jerkiness in body movements. The signals are dynamic due to sensations at the muscle spindles, and the signals are not constant. So if the muscle spindles are not functioning properly, muscle contraction appears jerky. The signal averaging function of the muscle spindle reflex. Forget what this chart is. Let's see if I can find. No, I saw that chart somewhere in my other notes. I would say this is the advantage of here we go. Okay, so this chart is literally just showing with the spindle versus not having the spindle, where the spindle smooths out the contractions and it makes the proper adjustments slowly, not necessarily slowly, but more fluidly, versus not having the muscle spindles, where it's very, very jerky, and so it's very hard to contain and control the movements. It's hard to get that fine motor control. Okay, so role of muscle spindle during voluntary muscle control, the alpha gamma co-activation. This is kind of what we already what we talked about. So muscle spindles need to maintain a level of tension to be effective. I don't love using that word right here, because when we talk about tension, we're talking about Golgi tendon organs. So they need to maintain a level of, I would say, a level of stretch, or a level of awareness to be effective. Just to make it a little clearer. If the muscle shortens during muscle contraction, the spindle must shorten to continue to provide feedback to the central nervous system. So co-activation of the alpha and the gamma motor neurons. When the alpha motor neuron activates, this is what we were talking about in this way back here. When the alpha motor neuron activates, it signals the gamma motor neuron as well to come back and to match the stretch of the muscle. So we already kind of talked about this earlier. This whole process If you can walk yourself through this process, explaining what happens in each of these steps and why that is happening, you will be golden. That is really what we really want to understand. Yeah. So you can read through this if you want. This is what we'd already explained earlier. Again, this is the same thing. What we explained earlier. Coactivation of agonist and antagonist muscle groups. Again, already explained this earlier. This is that part where we have the inhibition of the antagonist muscle. You also do get coactivate. You get any of the agonist muscles. So, for example, the quads. You do have other muscles that perform similar functions. Think like the TFL a little bit, or like in the smaller musculature in and around the knee. That's why when we do these when we look at these reactions, we super simplify them. There's a lot more to them than just like what we cover. We cover the main idea, but in reality, there's a lot more nitty-gritty little details to it. But this is what we really care about for now. So that coactivation of the agonist and antagonist muscle groups. I think he's actually referring to something different here. Interesting. I don't super follow this order, but that's okay. What he's actually mentioning here, this does occur, this inactivation for the actual reaction, like reflex to occur. This is outside of reflexes. This is just talking about in day-to-day life, like when we're standing. So if we're standing, we need in order to stabilize the joint. If I'm pushing, if I'm doing a push-up, for example, my elbow and my wrist and my shoulder all need to be stabilized. So we get co-activation of the agonist and the co-antagonist muscle groups in order to help control and to facilitate the proper movements and to keep control. Or like if I'm doing a bicep curl. And you should have done this in lab if you were in person or talked about it, where you hooked up some of the electrodes onto a bicep as well as a tricep, which are antagonist muscles to each other. And then you did a bicep curl. With that bicep curl, you should note that there's more activation in the bicep than there is in the tricep. There's still activation in the tricep. And that is due to co-activation. So in order to maintain that stability of the joint and make sure that the joint moves nicely and doesn't just like rocket all over the place when we activate a muscle, we get dual activation. So you get some activation of the antagonist muscle in order to help to control and to stabilize whatever joint that we're moving. Hopefully that makes sense. As I said, we're just going through this individually, or I'm going through this for the first time with you guys right now. Now the knee-jerk reflex. Okay. So the knee-jerk reflex, a little history for you guys. What this test actually is for, it's used as a neurological test to check the neurons, specifically of L4. Technically L2, 3, and 4, but primarily L4. To see if there is any kind of lesion or damage to either the spinal cord or the nerves going to the different muscles. Okay? If there's damage to the central nervous system, we call that an upper motor neuron lesion, and you will actually get hyperreflexia, so excess, so really strong reflex. If there is damage to the peripheral nerves, so the spinal nerves, like the nerves coming out, which you could get in something like a disc herniation poking on the spinal nerves after they've left the spinal cord, you will get a reduced reflex or possibly no reflex. So doing these sort of reflexes, and you'll learn a whole bunch of these different reflexes in your clinical neurology class. We do them to see potentially to differentiate if there is an upper motor neuron lesion or a lower motor neuron lesion, because the way that we treat those is going to be different. Okay, but continuing with this specific reflex. So the knee-jerk reflex, it is used to determine the sensitivity of stretch reflexes. The steps is first, the patellar tendon is struck with a mallet. This stretches the tendon. This stretch is conveyed to the muscle spindle, which is located in the quad muscle, and the frequency of action potentials increase. The action potentials travels back to the spine along which nerve? The type 1A afferent nerve. And when the muscle spindle shortens, the frequency of action potentials decrease. Okay, so the stimulus, muscle or spindle stretches and fires. The action potential travels through the sensory neuron. The sensory neuron synapses in the spinal cord. We get the somatic motor pathway with the quadriceps muscle. The quadricep contracts, swinging lower leg forward. And then we also have here an efferent path 2, where the interneuron inhibiting somatic motor neuron. So actually we'll come back here and add one thing to this here before we get to the alpha motor neuron of the hamstring. We actually will have a interneuron, an inhibiting interneuron. So I want to add that in right there. And that goes to the hamstring, and the hamstring stays relaxed, allowing for extension of the leg. So we already chatted a little bit about that. So now the clinical application. So the directly synapse with the alpha motor fibers of the stretched muscle fiber is monosynaptic, so the quadriceps muscle groups. Synapse with an interneuron that inhibit antagonistic muscle group is polysynaptic, meaning the hamstring muscle group known as reciprocal inhibition. This is our reciprocal inhibition, telling the hamstring to chill. And that is going to be a polysynaptic portion of it. The knee-jerk reflex is monosynaptic, okay? What we call the knee-jerk reflex is, where'd it go? This. The receptor in the quad gets the signal, sends it along a type 1A afferent, and it connects with the alpha motor neuron of the quadriceps. The somatic motor neuron comes out, that alpha motor neuron, and goes to the quadriceps muscle. Okay, that is the knee-jerk reflex. Right there, bum, done, end of story. At the same time that the knee-jerk reflex is occurring, you have an additional polysynaptic reflex, which is the reciprocal inhibition. Okay? Keep those two things separate, because that helps, especially asking questions. The way that they'll ask questions is the knee-jerk reflex is monosynaptic, true or false? Or which of the following describes the knee-jerk reflex? And monosynaptic will be one of those potential answers. Okay? So the knee-jerk reflex itself is monosynaptic. That extra portion of it, which helps assist in the knee-jerk reflex is polysynaptic, because it has an interneuron. This is just going over that reciprocal inhibition, which, again, we already went over. Clonus. Clonus is a fun one. So clonus means oscillation of the muscle contraction after the muscle spindle is activated. This is uncontrolled. This is uncontrolled or involuntary muscle contraction. This happens a lot with somebody who has issues with inhibition of the motor neurons. So a lot of neurologic diseases, think like MS, or even like after a stroke, after an upper motor neuron lesion. You can see clonus, especially like in the ankles or in the knees. So it's basically what you would see is the muscle spindles, the signal essentially doesn't stop. So when you One of the tests that you'll see is you actually grab the patient's foot. Let me see if I have something here that I could use to describe. Well, actually, let me go grab my leg. One sec. Just kidding, I can't. My baby is sleeping. Let's just use the internet. Okay, so what you should see, and you have the patient laying down or sitting. And so literally what you're going to do is you're going to take the ankle, kind of move it around a little bit, and then quickly jerk it up. And if somebody with ankle clonus, let me see if I can find a video of somebody who has it. So this is an example of ankle clonus after a stroke. See how it bounces like that? And that's because the central nervous system isn't able to inhibit that signal like it's supposed to. So that's ankle clonus. And you can have just a couple of beats of that, or you can have continuous sustained clonus like this patient. Very, very clear indicator of an upper motor neuron lesion or a central nervous system lesion. That's what we're talking about with ankle clonus. Okay, Golgi tendon organ. So all that before that we're talking about, this all has to do with the muscle spindle. Talk about the Golgi tendon organ. It's going to prevent excessive tension on the muscle. So it detects changes in tension, not length. It's found in the border between the muscle and the tendon. It's stimulated when tension increases on the tendon or compresses the nerve endings, and the response is relaxation of muscle stimulating nerve endings. You can have lengthening reaction. It is a protective reflex to prevent muscle tearing or damage to the tendon. This is kind of like if you've ever watched people lifting, and kind of like they just like their legs or whatever give out from underneath them. That's due to the Golgi tendon organ. Whereas let's say somebody's doing a squat, and then if you see, let me see if see if there's a video on here that'll show us. Ninja Nerd, always advocate for Ninja Nerd. I love Ninja Nerd. I don't see one here. Ooh, but I will. If you guys haven't watched any of John Gibbons' stuff, I watched a decent chunk of. I've watched a lot of stuff on YouTube to learn different skills and just kind of practice different things. John Gibbons is one I've watched. He has some really good stuff. But when we talk about this is getting to myofascial release, when we talk about the muscles, we can actually play with the Golgi tendon organs to our benefit. Where if you're doing a stretch, you can bring the muscle to a specific level of tension. So it's like a quad stretch or something when you're holding it back behind your leg. And you're holding or you have somebody else hold it, and then they hold it there for a little bit, and after a minute or so, your muscle just suddenly relaxes and you can go deeper. That's the Golgi tendon organ at work. It gets to a certain level of tension, and once you get to that tension, it actually causes the muscle then to relax, and you can actually introduce more into the stretch. So really cool myofascial technique that you can use when working with patients. So it's like something, for example, if my neck is super, super tight, I can introduce tension to it, specific to like the upper traps. As I'm going, there'll be a point almost where you'll feel it start to relax a little bit. And even there, see how I can get more stretch there? A little bit more. That's the result of that Golgi tendon organ telling the muscles to relax as it gets more and more tension on it. And that is a polysynaptic response at our inhibitory neuron. What is our inhibitory neurons? What do they release? What neurotransmitter? Glycine. Glycine inhibits, glutamate activates. Now we have the flexor and the withdrawal reflex. So this is commonly stimulated by a pain stimulus. Heat, pain, or a wound is a nociceptive stimulator. Nociception or noxious, nociceptive reflex. Polysynaptic. Multiple synapses with interneurons. The flexor muscles are stimulated and the extensor muscles are inhibited. So this is something like stepping on a nail or like putting your hand on a hot stove. We all know if you touch your hand on a hot pan, very quickly your hand will, if you touch the hot pan, it very quickly you naturally jump right off of that surface. And that's because of this reflex. Or if you step on a nail somewhere, stepping on the nail, you immediately jump off of that foot and land on the opposite leg. So, and that's our flexor muscles are stimulated. The flexor muscles pull away, and the extensor muscles are inhibited to allow for that quick flexion. That quick flexion. Additionally, let's see if he covers it. Yeah, he covered it right here. So the reflexor reflex is stimulated quick. After a few seconds, the reflex fatigues. Once stimulus is removed, after the discharge prolongs. After the stimulus is removed, once the stimulus is removed, the muscle tension is quickly restored. So then your muscle tension goes back to normal afterwards. So it fatigues rather quickly. So this is a very quick reflex, and then you're able to relax and move again. Move again like normal. The crossed extensor reflex. This is more, especially in the foot, but you can also see it in the upper body. At least I've seen it in the upper body. I've seen it happen similar to this, where let's say you step on something like a nail, and it's going to do the same thing. So it causes your flexors to contract, and it inhibits your extensors on the side of the pain. and then on the other side, on the crossover side, your extensors are going to activate, and your flexors inhibit. It's like, let me see if I can. Kind of really small, but let me see if I can demonstrate. So, if I'm walking and I step on a nail, my flexors and everything immediately activate, and it's almost like I jump onto the other foot. So step and I hop on the other foot. So my flexors activate, extensors are inhibited, my flexors activate, and then my extensors on the opposite side activate, and my flexors are inhibited on the opposite side. It's like, it's the reflex in order to catch ourselves. Going from, to get away from that painful stimulus. And that's that crossed extensor reflex. Another polysynaptic reflex, meaning that there are interneurons and stuff involved. And that is associated with the flexor reflex, where the opposite limb is stimulated to extend. You get the reciprocal inhibition, and after discharge, it is prolonged. So this one lasts a little bit longer than just the initial flexor reflex. Okay, and that right there, everybody, is this whole unit of the spinal cord motors. There's a lot more in here than just the reflexes, to be honest. I think personally these should be split up into a couple different things, but it's fine. Sorry, I know that this was a longer video, but there really just isn't a great way to kind of break this down. Let me see if there's anything else that I want to add. And here's a couple of PNS is peripheral nervous system disorders. So you have CNS and PNS. Here's some general disorders. If you want to pause and look at those. Type 1A spindle efferents are responsive to the rate of change of muscle length. Babinski reflex, Babinski's sign, this is when they actually go on the bottom of your foot and kind of scrape up and across, starting on the lateral side of your foot, or medial side of your foot, lateral side of the foot, and up across to the toes. Goodness, I should know that like the back of my hand. Yeah, lateral side is how they teach it. Go lateral side and up and across to the toes. And this is what you typically should see, and this is what a positive looks like. If you have a friend that just had a baby, do the Babinski reflex on them, because their central nervous system isn't completely myelinated yet. They actually have a positive Babinski reflex, which is pretty cool. Babinski sign, that's another sign that you look for. You can have hyperreflexia, or you can have an upper motor neuron lesion if you have a positive Babinski sign. Relaxation of the quadriceps muscle. This is kind of just some practice questions. Each muscle has one muscle spindle that's false. That has a whole bunch of different muscle spindles. Okay, like I said, this is kind of the benefit of going through this with. I have the two different sets of notes, because here, this is cool because it has a lot of similarities, but it also has a lot more additional information and stuff, and I feel like having both of these is very beneficial to kind of jump back and forth and go through them. Okay, have a great day, everybody, and good luck on learning.